Good afternoon, everybody, and thank you for joining us for this webinar. This is a series of webinars that NMAC is going to be doing while we are stuck away in our homes. And what we want you to know is that one of the primary purposes of this webinar is just to keep us connected. You know, for those of us who are lucky enough to be able to shelter in place, it is still a very isolating and difficult experience. At NMAC this week, we had a very tough week, and I don't know about your agencies, but we lost too many people. And so we want to do this webinar just to make sure that we can stay connected with everybody. As you can see, there are going to be 4 presenters today. Each of them will be doing a brief, and I say brief, PowerPoint presentation to talk about a variety of issues. And at the end of it, we will answer questions. What I'd like to do is if you could go to the right-hand side of your screen, and there's a little box that says questions. If you could click it so the arrow goes down. And what I'd like you to do is put your name, your agency, and where you are from so that we can practice asking questions and we could see about all the people who are on the call with us today. So Chip, who's on the call with us today?
We have Lori Jones from County of San Diego. We have Annie Kuhn, Brian Mingala from Legacy Project in Seattle, Stephanie Cornwell from CalPEP in Oakland, Jeff Berry from TPAN in Chicago, Keisha Wake Forest Baptist Health, Brenda Fields, Fayette, North Carolina, Dorian Macon of San Diego, Glenn Spencer from Aunt Rita's Foundation in Phoenix, and a lot of others. A lot of others.
Well, thank you so much, Chip. So right now I'm a potato. And part of why I'm a potato is that we just need to laugh sometimes, because if we don't laugh, we're going to cry. One of the things that I learned in the early days of the epidemic was how we use gallows humor to get through difficult times. And part of what's going to happen today is we're going to have about 20 minutes of presentations, and then we're going to open it up to questions, and you'll be able to ask any of the panelists any question that you would like. We will also be posting everybody's email address so that if you want to speak with them afterwards, you can email them directly. We should tell you that the slides that we are doing right now will be posted on the internet so that everyone will have an opportunity to go back and see what we did. And the final thing is that when we end this webinar, we're going to end it with an evaluation. And your evaluation is critical to us. You know, let me be honest, this is a new mechanism for us to do distant learning. And so we need your feedback to figure out how to improve it, what we did well, and please feel free to be brutally honest, because this, you know, we understand that we're just learning this. Like, do you like the fact that I'm a potato, or should I just be a regular person when I do this? So in terms of that, let me say that we're going to get started now, and I'm going to introduce our first presenter. And he is the Chief Operations Officer for the Federal Ending the HIV Epidemic effort. He is a friend of the community and someone who has worked side by side with us since the beginning. And so it's my great pleasure to introduce Harold Phillips.
Thank you, Paul, and good afternoon, everyone. Thank you for being here. Thank you for the work that you do. And this afternoon, I'm going to give you a brief update on some of the COVID-19 activities, as well as talk about the Ending the HIV Epidemic initiative and the work that we're doing in the Office of the Assistant Secretary to move the initiative forward. Let's see if I can. Yes. All right. So, and I'm going to be brief. So, many of you already know that CDC moved the due date for its NOFO for EHE implementation from the end of March to May 1st. With this move, awards will be made by August 1st. So again, we'll be getting the money out this federal fiscal year. COVID-19 and people living with HIV and federal resources. There's a lot that we don't know, and Moises will talk about some of what we do know as well. But as the federal agencies have been putting together briefings and guidance, we've been posting them on hiv.gov/coronavirus. hiv.gov is a good resource, and we will continue to continuously update the website with materials from the federal partners. Many of you also know that we have been looking at different ways to support telehealth as a modality that fits in with our social distancing, but also can help individuals access care, continue in care. So HRSA, CMS, the Office of the Inspector General, and CDC have been working together to put guidance out, as well as additional funding that I'll talk about later to support telehealth. One important piece from the Office of the Assistant Secretary for Health that was released yesterday, there was new guidance under the Public Readiness and Emergency Preparedness Act, which authorizes licensed pharmacists to order and administer COVID-19 tests. This is for both retail and community-based pharmacists. So this is another way that testing should be expanded for COVID-19, probably starting next week, since the guidance was issued yesterday. Many of you have heard about the CARE supplemental funding. On this slide, I talk a little bit about some of the funding that's gone out from HRSA to the health centers yesterday. CDC will be making awards to state, localities, and jurisdictions for COVID-19 preparedness and their response. HRSA will award $90 million to Ryan White programs to address COVID-19 among those living with HIV. It's not known yet how HRSA will distribute these funds and how they will go out. So stay tuned for this. It's definitely something to watch. Indian Health Service received funding as well for both those on reservations, but also urban Indians as well. And SAMHSA applications are due from states and territories on Friday. In terms of EHE, it remains an administration priority. Admiral Giroir restated this to the team on March 16th. We have begun in earnest a lot of the work that includes putting public health service officers in Region 4, 6, and 9. We have been working with the Jumpstart sites in Baton Rouge, Baltimore, and that Cherokee Nation, and those are moving forward very well. We're learning a lot from those cities, and we will plan to release some of the successes as well as some of the challenges when we release the dashboard in June. We have awarded funds and continued the HHS PrEP program, Ready, Set, PrEP, and the federal agencies continue to meet on EHE and figuring out behind the scenes how we can move forward while respecting what's happening within the jurisdictions. Some of this includes the dashboard, which will be released in the middle of June. It's showing our targets and our indicators and a way to monitor our progress in reaching the 5 and the 10-year goals. We're continuing to work and develop collaborations with our federal colleagues who can support us in the EHE work. And we continue to work with and develop strategies to work with other sectors of society, such as the American Medical Association and others that are healthcare professionals. April 1st, the co-sponsoring pharmacies that you see on the screen, they all began their work in earnest. These are the only pharmacies where enrolled patients can receive their medication. They can receive them by picking them up or by mail. In the 24,000 combined locations, the pharmacies have donated both their services to distribute PrEP as well as the mail order piece as well. They also will provide patient counseling and support patients to adhere to PrEP. Our Ready, Set, PrEP program, many of the materials, again, on hiv.gov. Please take a look at them. You may be able to download them. You can download them as well. The social media kit also available for you all to use. Final messages. What I want to say, and this is as a person living with HIV, that it's important that we stay in care, that we monitor our supply of medications and ensure that we have an adequate supply, that we talk with our case managers and nurses or doctors to find out if they're using telehealth as a modality. Telehealth can also not necessarily be video, but also by telephone. And another important thing to do right now, create, if you haven't already, a list of emergency contacts and a list of medications that you currently take, and post them on the refrigerator in case you do become ill and have to go to a clinic or a hospital. All that information could be readily available for someone who is assisting you. Also, this is a very difficult time, as Paul talked about, and we have to give ourselves permission to acknowledge that this is difficult. There's a lot that we don't know right now. There's a lot that's being slowly figured out. It's an uncomfortable place to be, and so acknowledging that also helps. Practicing gratitude. Don't focus on what we've given up or what we've lost. That's another key strategy that helps keep me together. Also staying mindful and present, both in mind, body, and spirit. Finding ways to recharge and renew as needed. Another great tool is SAMHSA's online resources, which are also on hiv.gov. It includes tips for social distancing and quarantining. Develop and use your support network. Call family, friends, video chat, check on the neighbors. And again, we'll get through this together because of our kindness, our caring, and we will follow the science. People working in the field of HIV are bound by a passion and a commitment for a better day, and we're going to have a better day after this is all over. So with that, I will turn it over to Moises.
Thank you, Harold. Good afternoon, everybody. My name is Moises Agosto, and I'm the Director of Treatment for NMAC. And I am also a person living with HIV. I got tested in 1986. I have like 34 years living with HIV. I am a long-term survivor, as I mentioned, and I am also a person over 50 with HIV and aging. The reason why we wanted to give some kind of considerations, special considerations that we should have for people living with HIV. It is very important that we, I'm having trouble with the slides. Okay, these considerations that I'm quickly and briefly going to go through have been developed by IDSA and HIV-MA, as you know, giving us some sort of best practices. As we know, we don't have enough information or data about HIV and how it plays out in people that acquire COVID-19. So in order to provide some sort of a guidelines, these guidelines are being extended for clinicians and public health officials and service providers. For if you are a clinician or work in a community clinic and you need some guidance in terms of how to clinically address the issues of your patients, you can also go to the HHS interim guidance for COVID-19 and persons with HIV. If you need some information about drug interactions, also with COVID-19, it's good that you are aware of these interactions and that you write down all your medications, not only your HIV medication, but also all the medications that you take for other conditions like cardiovascular disease, high blood pressure, or diabetes. In terms of like seeing your doctor is for patients that are stable, that have a stable viral load, undetectable, and a good number of CD4, there is no need for urgent appointments, and you can schedule your appointments via telephone or also utilizing telehealth that a lot of doctors and other clinics are using at the moment. In that way, you don't expose yourself outside to be exposed to the virus that caused COVID-19. For people with HIV that have not like respiratory urgent concerns, also keep your appointments via telehealth. And you can find patients that are on Medicare or Medicaid. Also, they are provided with telehealth coverage, and it's available through the Resource Center for these guidelines. We have, as I said, insufficient data that suggests or give us parameters in terms of immunologic risk for severe disease. It's important that in terms of care and treatment for people with HIV, you follow the same protocols that is advised for patients that don't have HIV. As noted in the guidance, HHS guidance, there are no data indicating that people living with HIV will get sicker than people without HIV or will have worse outcomes. So we don't know exactly that. But in terms of getting tested for COVID-19, people that are experiencing signs and symptoms in terms of a lower respiratory tract illness should be prioritized, and it regardless of the viral load status and the CD4 cells amount. In terms of care and treatment, in people with HIV should generally follow the same protocols advised for patients without HIV. One point that is important to highlight is that 50% of the people in the United States living with HIV are older than 50 and may have comorbidities that are characterized as comorbidities that put people at risk for or being more severe, have a more severe disease with COVID-19. We're talking about cardiovascular disease, hypertension, and diabetes. Until we have more data, we consider HIV patients that we will consider those that are more advanced and that have problem controlling their viral load and that are showing symptoms. Antiretroviral therapy should be continued. Interruption should not happen, and changes in therapy are not recommended unless you have a doctor working with you and is absolutely necessary. In terms of the viral load monitoring, patients that have undetectable viral load, they can postpone their appointments with their doctors, and those that are having problems in keeping their virus suppressed and or have some challenges with adherence or have resistant concerns, they should be prioritized for COVID-19 testing. In terms of prescription drugs, as was mentioned before, patients should have at least a supplemental of 30 days. You should work with your doctor, work with your clinic, and also for those that are on ADAP, they should contact the local ADAP program. It's the same for office visits. If you're stable, you can schedule something via phone, via telehealth, and for those that are more showing symptoms, they should then talk to their doctor. Measures should be the same in terms of social distancing, and washing your hands or cloth masks are recommended. Now I'm going to pass it to Ace Robinson.
Thanks, Moises. Yeah, my name is Ace Robinson. I'm the director of the Center to End the Epidemics here at NMAC. So I think, as many of you know, my real focus in this work is how are we going to address the disproportionate impact of HIV and other associated illnesses similar to COVID-19 on particular communities. And unfortunately, as we've seen with COVID-19, especially in the last few days on the news, that COVID-19, I think at one point was called the Great Equalizer. But then now that we're getting a lot of data from our health departments and some preliminary data from the CDC, we're seeing that there is a disproportionate impact of COVID-19 and morbidity from COVID-19 in particular communities such as the Black African American community. Now, we already know that COVID-19 is America's current health crisis. And we see that almost 500,000 people in the United States have been diagnosed with the virus. That is almost 1/3 of the world's total diagnoses. And unfortunately, we have seen over almost 15,000 people have died in the US as of the 85,000 who have died worldwide. And we're really starting to see what communities are being impacted, and how are we going to, we need to also begin addressing how are we going to address those disparities. So who gets sick, and they're like, who gets sick from COVID-19, and how does it progress? One thing is very clear, that everyone is susceptible to COVID-19. So those myths and misconceptions that certain populations or certain kinds of people can't acquire COVID-19, that's simply not true. And we're seeing that it's really impacting older individuals, people over the age of 60, and then others who have underlying health conditions. So from the CDC, our health departments, from the World Health Organization, we have seen that people who have high blood pressure, heart disease, diabetes, pulmonary issues, and untreated HIV are more susceptible to acquiring and then also progressing with COVID-19. Now, I guess that real question is, like, when you're looking at those underlying conditions, who is going to be most impacted, just because like that has already been true for them well before COVID-19 was on the scene. So when we're talking about high blood pressure in the United States, the most impacted community by scope and scale are unfortunately Black people. The same is true for heart disease. Diabetes, the most impacted group is also Black people. And when it comes to untreated HIV and HIV mortality, the most impacted group is also African Americans. So knowing that information, then we go into what is going to be the underlying impact. As expected, like it was what many of us were raising the alarm to a couple of weeks ago, that this is really going to be centered in communities that already had those underlying conditions. We're seeing it playing out. Like in the urban settings, whether you're in Detroit, a place like the state of Michigan, where 1/3 of the state of Michigan are identify as Black African American, but 70% of people who have been identified with COVID-19 are African American. Same is coming true in Chicago. We've seen it laying out in New York City, where in Queens and East New York, they're overrun. Wherever you find Black and Spanish populations, the COVID infections are just they can't be handled. And we're also seeing this playing out also in New Orleans. Now, this isn't just true in urban settings, it's also true in rural settings. So we're looking at places like North Mississippi, Albany, Georgia, and South Georgia has been all over the news when they're looking at these high concentration of COVID infections in communities where there is no urban core center. And you see the data there, where you're just going through Louisiana, Michigan, Illinois, like where we're looking at coronavirus mortality as for Black people as it compares to white individuals. Now, like as I was saying, like these communities are not always centered in the north and northeast or the north. A lot of them are centered in the south. The most impacted population, when they do the population scaling, like how many infections do you have per population? And the most impacted region in the US is Detroit. But look at those other 8 of the top 9 impacted regions. They are all centered in the South. I already spoke about Albany, Georgia, and spoke about Mississippi, and spoke about New Orleans. But then look at Arkansas. 2 parts of Arkansas are highly impacted, both Little Rock and Pine Bluff. And then we go into that conversation of like which states are having a very aggressive response to the COVID epidemic, and which states are still being led by individuals who aren't sure if COVID-19 is all that bad, or is it just more of a left-wing hoax? And we're seeing how that's disproportionately impacting communities that are predominantly Black. Now, as is all this information that I'm laying out, it does sound very, very familiar. Like in the world of HIV, we look at which communities are disproportionately impacted in the US and where you have the highest rates of HIV acquisition and unfortunately death due to HIV complications. And that is the African American community. And then we speak about where are those people living. The majority of people living with HIV reside in the South, which falls exactly in line with that previous graphic that if we don't get a hold of this, we're not going to just have these little hotspots. These hotspots are going to end up having COVID-19 taking over an entire region of the country. And so a lot of these conversations revolve around social determinants of health, or in the streets, a lot of people just call that racism, sexism, homophobia, transphobia. When we're doing this work, when we're talking about the nuanced needs of healthcare, we're talking about things like food security. I'm not going to talk to you about your healthcare if you're worried about where your next meal is coming from. The same thing about if you have a place to stay. And then we have to look at like the type of world that people are living in. Are you living in a place that has high levels of pollution? You have other environmental toxins that might lead to pulmonary disease like COPD or asthma. And then that whole conversation about access to healthcare. So if you're looking at, you already are maybe suffering from diabetes, like do you even get to see a primary care physician? Do you have access to affordable insurance? So when we're looking at parts of the country that have not taken advantage of the Affordable Care Act and have expanded access to health insurance, the people who live in those places who don't have access to a lot of resources, do not have a job that's going to cover their health insurance, those individuals are not going to be maintained in care. And then we always speak about access to education. And what we're seeing full on right now with the COVID pandemic is, do you have access to a job? And if you do have access to a job, what kind of job? Do you have the WFH? Can you work from home? When we're talking about teleworking and all those types of things, that is only for a particular subset of the population. If you're doing delivery, you work in hospitality, you still have to go to work. You have to keep food on the table. You have to keep housing over your family's head. And so you're still in that crunched environment on the subway or around your colleagues, and your ability to have access to N94 mask is highly limited. We know that. So when these conversations are going forward, we have to really understand that in that center, you see that person in the center, there's a lot of other pieces that are impacting them. So I want to finish up talking about, this is really what's happening within the Black community, but we also know from the work that we have done in the HIV field that it was always going to be the communities that don't have the same access and resources and also the same protections by law. So we're talking about racial and ethnic minorities, and especially the immigrant communities. We're going to be very concerned with making sure that folks who have already gone underground because they're worried about immigration groups or police group or the police coming after them if they're just walking the street and going to their doctor's appointment, people are moving out of care. We've seen through a lot of the work of all of our colleagues what's happening for incarcerated individuals, where there's been a big push to make sure that incarcerated individuals who are nonviolent are being removed from the jails because the jails are overcrowded. And then now that COVID-19 has been introduced in them, for a lot of individuals, that's going to be a death sentence due to the limited health care that's available while you're incarcerated. And how are we going to support the homeless population and, of course, sex workers who quite often are losing their main source of income? And we're trying to look at how they're going to survive in this world. So going forward, I want you to make sure that we keep you updated. NMAC has created a resource page that you'll see in your chat box that is going to stay updated with what is coming down the pipeline. Every day we get some different news about the etiology or the progression of COVID-19 and how it impacts our communities. And then we're also adding a new page that's going to be an FAQ and an info sheet that is for individuals who don't work in public health and public policy. We want to make sure that the language is very clear and very community-based. So thank you for your time. I will turn this over to Tara, and she'll update us on USCHA.
Thanks, Ace. Hi, everyone. My name is Tara Barnes-Darby, and I'm the Director of Conferences at the National Minority AIDS Council. We produce the United States Conference on HIV and AIDS, as well as the Biomedical HIV Prevention Summit. I am here to give you an update on the status of USCHA this year in terms of whether it's going to happen. Like other conference planners, we're in a wait and see mode as we assess the current state of COVID-19 in our communities. As of today, we're still planning on moving forward with the current dates of October 10th through the 13th to have an in-person conference. Any decision to cancel or postpone will be made based on our ability to have a safe and healthy conference environment for everyone involved. This includes other logistical issues, such as making sure that people can travel safely and that there are enough flights to San Juan to make sure that people can actually get there. So we're going to be making this decision at the end of May or the beginning of June. So stay tuned. What are our options? Other alternatives are to cancel the meeting totally or to meet virtually. If we don't have an in-person meeting in October, we'll likely postpone the meeting to the spring of 2021. We've made a commitment to Puerto Rico and are pushing to have the same in-person experience that everyone knows and loves versus having a virtual conference. But we haven't made a decision yet, so we want to hear from you. What do you think that we should do this year? So what this means is that you can continue to register, apply for scholarships, reserve exhibit booths, as well as reserve your hotel rooms. All of our forms and processes are still active on the website, and you can still reach out to us at conferences@nmac.org. If we decide not to have an in-person conference this year, NMAC will offer full registration and exhibit refunds. So you don't have to worry about losing your money. However, I do advise against making your flight reservations at this time. Just wait to get the official update from us. If you have any questions that I haven't addressed, I know that was very brief. Right now, this was not a programmatic update. It was just to kind of give you an update on what we're thinking about whether the conference should happen. But submit your questions and we'll answer them at the end of the call. Thank you. Tossing it over to Chip.
Hi, everybody. We are back. Welcome, welcome, welcome. Hey, hey. I hope you found that of interest. I can hear some background noise from somewhere, so we'll have to try to figure that one out. Maybe other people can mute their phone. Yeah, thank you so much. So what I'd like to do now is have you ask questions of any of the panelists. You can put your questions into the question box, and Chip will answer it. Chip will forward it to us. The one thing that I want to just remind you again is that your feedback is essential for the system. You know, this is all new to us, and we're learning how to do it. And to be candid with you, this was not a vehicle of training that we were particularly proficient at. And so we really want to learn, because unfortunately, we think this is going to happen for quite a while here. I should also let you know that we will be doing weekly check-ins with everybody on a variety of topics. So as you're filling out your evaluation form, tell us what you'd like to hear about. But with that said, Chip, what's the first question?
So our first question is, can technology be purchased through grants to assist orgs become better equipped to telework and offer telehealth services?
Are you talking about through the PPP, or are you talking about through your government contract? If you're talking about through your government contracts, my recommendation to you is that you speak with your project officer, that they're probably going to be the best resource to tell you this. My sense is that it is all changing very quickly, and we're all trying to figure out how to adapt to it. In terms of the PPP loan program, you cannot purchase equipment through that. It really is a program that focuses on salaries, benefits, and rent or mortgage interest. Next question, Chip.
San Diego County has stopped doing in-person outreach for HIV prevention, but is still doing homeless outreach. What are others doing with respect to outreach? Any recommendations? We are doing online outreach. Are people planning for National HIV Testing Day and Pride events over the summer?
I'm going to ask Harold to answer that question first, and then see if anybody else has any answers.
Well, I do know that many Pride events have been canceled for the summer. The way that we're approaching outreach right now at HHS, we're changing our strategy to be one of a digital strategy primarily, at least for the next couple of months. So we are not doing site visits or town hall meetings. Instead, we're going with the virtual format and using the web and streaming services and trying to get the word out about EHE and Ready, Set, Prep in that way. So I imagine that a lot of the outreach that might be happening in the community is going the same way, or should definitely think about it.
Anybody else want to say anything?
Yeah, so there are quite a few organizations that have begun expanding their education around home testing when they do not have the PPE available to do person-to-person to face-to-face testing. And you might want to look into the availability for reimbursement models for helping people through their telemedicine as they do their self-swabs and their own HIV testing to be sent into the labs. Because as we've seen through the majority of states in the U.S., the non-essential laboratory services are closed and you can't go in. So at-home testing is a way to go forward. And there has been, CMS has given waivers for the states to choose to upgrade their telemedicine protocols. And so that goes state by state. California has been one of the states that has been very liberal of ensuring that their telemedicine structure has been improved. So in San Diego specifically, you will be able to expand that, expand your visits through telemedicine, and then send the kits out for screening and return.
Harold, do you want to talk a little bit about the expense issue around home test kits and some of the concerns about, while we really want to support this expansion, we're also as a community very concerned about the cost of home test kits?
Sure. We've been talking to the manufacturer of the home test kit, and they are working on dropping the price for buying in bulk, and we are working with CDC and HRSA to see if there's some arrangement that we can make to increase the availability and access to home testing right at this point. Because as Ace said, it is a viable option, but for many, it's too expensive. So we're trying to work through some of those issues.
Great. Next question, Chip.
I understand some HRSA EHE funds have already been awarded. For any of the EHE funds, are extensions of program deliverables, funding deadlines anticipated?
I don't know the answer to that one. Harold, do you know the answer?
So I know part of the answer to the question. So yesterday, the health center program did make, at HRSA, the Bureau of Primary Health Care, did make awards to health centers. The details and the specifics regarding your notice of award, you should really talk to your project officer about that piece of it. The Ryan White Awards have not been made yet.
Next question, Chip.
If USCHA is moved to spring 2021, does that alter the schedule for the conference moving forward?
No, it doesn't. That would just be a one-off.
Tara, I didn't completely understand your answer. Could you say it again, please?
Sure, sorry. No, it wouldn't alter the schedule. So basically, it will look like we most likely will have 2 USCHAs next year. So this will just be a postponement.
Great, thank you.
But we haven't made a definitive decision yet.
Great. Chip, next question, please.
This one's for Harold. Can you please clarify the funding from the federal government to COVID-19 testing for HIV patients? How might that work?
So again, there was $90 million awarded to the Ryan White program, and the details, they have not worked out yet or have not released them on how they will distribute that $90 million and what it will exactly target. But it is designed for people living with HIV and COVID-19.
Next question.
As a PrEP provider navigator working from home, any tips or advice for helping clients with support and adherence? Our labs will not provide lab work for non-emergencies, and we are currently providing rapids only in the evenings, but many clients have fear or anxiety about visiting the clinic.
Moises, do you want to address that?
Sure. I mean, I think like under the circumstances that we are, maybe, it would be better to look for ways in which we can facilitate people getting their prescriptions under PrEP, but basically in a way that they don't, expose themselves to COVID. So I don't have a specific information about any system that is in place in order to provide PrEP, but most of what I have heard has been done virtually through telehealth. Most of the interventions that I have heard people doing at this time.
Harold, do you want to talk about Ready Set PrEP and what they're doing during this time?
So during this time, actually, Paul, I don't know. I haven't gotten a report yet on how they're working that piece of it out and new enrollments. But just like we've been talking about, I think the struggle or the difficulty would come in obtaining an HIV test right now when the priorities have shifted.
Next question, please.
Can ACE please repeat the NMAC.org response to racism resource link?
I'm sorry?
Can ACE please repeat the NMAC.org response to racism resource link?
So let me see.
It's the COVID-19. I'm sorry. It's the COVID-19 resource link. Chip already put it in the chat box, but we'll put it in there again.
We will also post it online, and you can find it at nmac.org. Next question.
Let's see. Will the webinar recording be available to view later? I'll answer that one. Yes, it will be available tomorrow on the COVID-19 resource page on NMAC's website. Any other questions? That's the last one we have right now. Anybody else has any more questions?
Great. So let me ask you a few questions while you're thinking about this. I think the first question that I'd like to ask you is, would you rather have a postponed USCA to the spring of 2021, or would you rather do a virtual meeting this October if we have to cancel or postpone the meeting? Virtual versus postpone. Any thoughts? Next question.
Person who the PrEP navigator. So looking at some of the chatter and some of the PrEP navigation listservs, what has been very helpful, number one, is to make sure that each of the providers get their SOP for right now. Many of the providers are willing to give the 90-day prescription even without having the confirmed HIV test, because they understand this is a different system. And so when you're looking at clinical care and having to change your SOP, that is absolutely necessary in order to access your PrEP. And then the second piece for the PrEP navigators is they have to start utilizing a PHQ-4 or something to that line to make sure that to review the person's level of isolation, which is true for absolutely everyone who is social distancing right now, who might be having higher levels of depression, anxiety around our new normal for now. So to make sure that those people are fully understand when they need to access behavioral health care, so that they don't make any choices that might compromise their health going forward.
I think that's a really important question. If I could ask the panelists to speak about, how are you addressing the social isolation in your life? And because we also know that social isolation is kind of the first step towards depression. And so what we have to do is figure out, how do we manage that social isolation so that we don't go down a rabbit hole that we don't want to go down? Moises?
Yeah, I think that first of all, you have to make a list of those people that you are close to, that you can reach out virtually. I think that at this point in which we have to keep the social distance, building ways of interactions with others via, let's say, Zoom, by conference call, by the, for example, and the other day I gathered all my family in Zoom, and we have an opportunity to exchange. The same thing could be done with friends. And I mean, in my family, we stay in touch every day. And in that way, we check on each other and we make sure that, you know, the isolation that we may feel, it's, you know, we have the backup of our friends and families. So that's one way to do it.
Harold or Ace or Tara?
I've been on the phone an awful lot with family and friends. Yesterday, I did my first Zoom happy hour with a friend in Boston. We had wine together and just caught up. I have another one tonight at 6 o'clock. So still staying in touch with people, still trying to do things virtually that make sense, that make us feel better. And it gives us a chance to see one another as well.
I would say that I'm definitely checking on my family much more than I typically would. And as someone who is, I don't use a lot of technology, it kind of pushes you into it, but I'm grateful for it because it's enabled me to connect more also with my niece and nephew too, so.
I think it's really great to connect with individuals, but speaking to the folks who are in different situations, or making sure that you're connecting with your Narcotics Anonymous, your Alcoholics Anonymous, like making sure you're connecting with individuals who can support you through the challenges that you've hopefully are beginning to overcome in your life, because this is a scary time and it's easy to go back to old habits, especially while you're having higher levels of isolation. And then for all the individuals who are experiencing domestic violence, like, you know, taking the time to go, many of the pharmacies have some code words that are available. Like if you go to the pharmacy and you say that you want your medication 19, like many of them know that means that you need to be taken to a separate room, because as we're seeing a spike in attacks due to victimization through DV, domestic violence, I want to make sure that everyone stays safe, because like as we're checking up on each other, some of us are in situations where being at home, more so with your roommates, your spouses, your children, parents, that might be highly dangerous for you. So always take care of yourself and look for other options out there, because it's a scary time for many of us.
Oh.
You're on mute, Paul.
Sometimes you just have to laugh and you just have to smile because, you know, who would have thought we'd be like this? Nobody. You know, this isn't something that any of us planned for. There's not a book on how to socially isolate yourself for 30 to 60 to 90 days, which is what it's looking like it's going to be. And so there's not a playbook. And we're doing the best that we all can with what we have in front of us. And I was telling staff that reminded me of the early days of the epidemic when people were dying and you know, we were kids planning funerals. We were kids going to the hospitals. There wasn't necessarily a right or wrong way. We just knew that people that we loved were getting sick and dying. And what I learned from those days in the epidemic is that when I came from a place of love and not hate, I could survive. But I'll tell you, it was really easy to let the hate take over my life and to let the bitterness take over my life. And so part of reaching out and talking to all of you is taking the time to make sure that that doesn't happen. Chip, are there any more questions?
Yes. Overwhelmingly, everybody prefers a postponed conference to a virtual one. But there was one question that came up. Did you already choose the site for the 2021 conference? Could you make the 2021 conference in Puerto Rico? I'm not sure how many can afford 2 conferences in 1 year and would have to choose.
That's a good point. We actually are already signed as far as a contract for DC. If you recall, we're kind of on this rotation with DC every other year, and 2021 is our DC year. But yeah, that's a good point. It's something to consider, and we'll discuss it.
Any other questions, Chip?
Yep. Taking into consideration some of the impacted areas have high Latinx and immigrant communities, is there any links or information that you know for this population online?
Yes, so the Trans Latina Coalition, in partnership with quite a few advocates, has been not only putting together webinars and resources, similar webinars. They also have some great resources out there. I know Moises and Damian and Miguel Angel at NMAC have been part of these conversations and leading the way as well.
Yeah, we have been working on putting together also information related to COVID-19 and specifically targeting the Spanish-speaking population, which mostly are those that have been dealing with like immigration issues as well. So we're working on that.
Please go to our webpage and you can see them. And Chip, any more questions?
No more at this time.
Well, then I want to just say thank you, everybody, for joining us for this webinar. We really appreciate how much effort it's taking to continue to work during these difficult times and understand that nobody has the answers, and we're just trying to do our best. And we love and support you. And feel free. Chip, did we post our email addresses?
Yes, I posted them all in the chat box.
So please, in the chat box, you will see our email addresses. Feel free to contact any of them. Not me, but feel free to contact any of them. And I know that they will be happy to answer and get back to you. And we will talk next week. Thanks, everybody. Have a good day.
Thank you. Bye.